years ago. We started this with our genetic test that we were doing at the hospital and with the CAC scoring. And we created posters for the examining room. And the poster linked CAC scores and genetics to families. And it simply said, if you have a family history of heart disease, you want to know whether or not you have heart disease. You know, CAC scores are available, gene tests are available. So what happened was that as the physician walked into the room, the burden was taken off the physician. The patient said, hey, tell me about this. I have heart disease in my family. Tell me about this gene test. Tell me about this calcium test. And the physician simply had to say, well, yes, that's available. If you'd like it, you know, it's $100 and stuff, and you like that test. And by and large, the patient said, yeah, it's a great idea. So the physician didn't have to convince the patient. The patient asked the physician, because he had a very simple, inexpensive poster he had a wall. So take the burden away from the doc of trying to explain why you need it, get the patient interested in it, and have them ask the doctor. It's very simple.
You know, we have used this strategy for several of our IRB studies where you don't want to tell the patient about something that you're doing, and yet you want them to know about this, and you put flyers and posters out in the waiting room. I don't think that strategy works. It works for very health-conscious patients or very educated, very motivated patients, but it's really not the same as, you know, you would order an EKG or an echocardiogram in your practice as, you know, as you deem appropriate. It works for a very small minority of patients, I think.
Dan?
Yeah, in being in Los Angeles, and about 10 miles away from Matt, with a program that has tailed down, well, this is increasing. All I can say is, whatever he's doing it right, and we got to listen to him very carefully. And I completely agree with what he said about having these sessions with your doctors and telling them what it's all about, and then trying to get decrease these questions that are there. Once you get started, it sounds as though if you have the leading physicians in your community who really buy into it, then it makes other people start to come and get it.
As far as practicing physicians, you know, not cardiologists necessarily, they want to know what to do with the test results. Most of them are not clear. I mean, Matt is clear when they come to them, but Matt, you're not treating them. So how much work do we need to do in order to get through this barrier that the physician understand clearly what to do with test results? And that's what you are educating them in your workshop?
Our reports can tell them what treatment targets to achieve. And I think if we had the shape guidelines that further reinforce that it wasn't just my recommendation or Dan's recommendation or Jim's recommendation, but this comes from a society, then it's even a stronger recommendation for a treatment algorithm. The higher your score, the higher your IMT, the more plaque you have in your common carotid, the more statin therapy you need, as a simple example. And I think that's going to totally reinforce what we're saying, because it's now endorsed by a society and not just a local idea.
Well, testing brought the most important issue, and that's reimbursement. And as you know, in the state of Texas, we were able to pass a law for that, but we have still serious problem, and we'll get to that because we're talking about adoption. Even when you have reimbursement is approved, there are barriers that prevent wide adoption. In the interest of time, let's move on to experience from Canada. If Mark Lovell and
Mark, let me
yes.
I have one question here. We talked before, George talked about the ACC, and I think a number of years ago, in the last statement on coronary calcium, the ACC said may be reasonable in the intermediate risk population. I think the best chances for widespread implementation are a stronger statement from them. Now, the next stage would be is appropriate. I don't think that would do it either. I think it would have to be, should be done in the intermediate risk population, just like measure your cholesterol, check your blood pressure, get a test for subclinical atherosclerosis. And I know, Matt, that you're involved in future statements. I'm sure you're bound by secrecy to some degree. But
well, we're moving up to 2A recommendations, so we're going to be in a very good place for both IMT and for calcium scoring and for ABI. we'll be in a very good place from the ACC for all of these tests. We're not going to get a class 1 indication, must be done, but we're going to be is recommended or, you know, is reasonable, not, you know, may be considered for people born on, you know, August 23rd and whatever. I mean, it'll be a much better statement across the board, and the indications are being broadened. So, you know, it's embargoed, but it should be out soon. The final data is approved by everybody, so we should have it out.
Joanne?
I just want to say one thing. I think what Harvey said and what Matt said is the key. I think once ACC at least recommends this as the appropriate standard of care, then you'll see more insurance companies pay for it, and you'll see more physicians doing it because of one fear that you don't have listed there, and that's the fear of malpractice lawsuits. So I think that fear could trump all the other fears. And so I think that, to me, looking at this as from the perspective of a lawyer and a little bit of an outsider, I think that's the key. If you get it to become a recommended standard of care, then I think more physicians will jump on the bandwagon. They'll take the initiative to learn more about it, and you'll see more insurance companies begin to pay for it.
That's a very good point. The fear of malpractice. We never used the fear factor, though there were several lawsuits. Waves and news in the media and created during that time spike in using CT scan. But you just brought a very important point. Would that be a good angle for education? Where as we go out, we're saying, let's say ACC guidelines came up, but keep that in mind, ACC or HA guidelines are not really communicating with the primary care practitioners. They don't know a lot about most of the things that advanced guidelines come in. They deal with basics, diabetic detection and management of diabetes. So, but we've never incorporated that angle of telling them if you don't do it, you could be sued, you could be doing this, and that has. Could you comment a little bit on that? Should be included in our educational program? For example, the kind of program workshops that Matt has had. Jeff is going to tell you about that he started his planning for SHAPE. Should we include that in the curriculum, in the education of these seminars, that if you don't do it, you could get yourself in big trouble because these patients now know and there are guidelines, there are awareness, and you're being educated about this, but you're not pursuing it. Joanne, back to you. Do you think that would be an angle of education by fear?
Well, I believe in the soft sell. I don't believe in trying to scare people into doing the right thing, but I think you can certainly intimate that if something is the accepted standard of care in the medical community and you don't follow it, then there are consequences that flow from that. You don't have to mention the M word, but I think doctors are smart. They'll understand what you're getting at, and they want to make sure they're not only doing the right thing for their patients, but they're not getting themselves into trouble.
Sure. Great.
Yeah, I'm regarding the 2A. That's a big deal to get, and Matt deserves a lot of credit for getting it that far. When that comes out, I think that it would be important to make sure that becomes widely known, publicize it, and to at the same time publicize the 1 millisievert radiation associated, so that you dispel any kind of concern about radiation. And with it, I mean not with the IV, with the calcium score.
Sure.
And then I think that it's conceivable that as time goes by that a kind of statement could come out along the lines of a new standard of care. So if we get the idea out, it's not standard of care yet, but if we got the idea out that it's standard of care, then maybe some of this would indirectly cause people to think more about it.
Great.
So the timeline for when the 2A recommendation might be coming out?
The executive summary was circulated, I would guess, September.
Of this year?
Oh yeah, no, it was due out in May. Oh no, it'll be out probably September, probably out a month.
I mean, that's really a groundbreaking thing.
Yeah, no, I
That's
mean, I
really
think
what we
Alan Taylor and I represented, and Leslie Shaw as well, represented calcium and carotid IMT. And I think the data was compelling enough to at least the writing group, and so far we've gotten no pushback. I think they'll be impressed with the breadth of, especially with calcium score, just because there's so many papers on it, the breadth of coverage that they're going to recommend. Diabetics, low intermediate risk, 6 to 20%, and that's why I would encourage us to somewhat emulate that in shape 2, so that we're concordant with ACC rather than not. I would just say one other thing. One thing that I think we're going to be very successful with in California, not as successful as Texas, but we went to the insurance commissioner in California. There's this center for whatever, the insurance commission who oversees the Blues and United and Aetna. And we showed them this thing that says it's experimental, and then I showed them, 1,000 papers and 20 years of research, and he says, why is it considered experimental? And I'm like, I don't know when that term should go out of vogue, but after a certain number of critical papers, probably the term experimental is no longer fair. So they are actually talking about suing the insurance companies to force them to cover it. So it won't be quite as good as having a law, but they want us, the insurance commission wants to set a precedent for this. So I think there's opportunities here. You can go to, once we have this ACC paper, I think you can go to your local insurance companies, or maybe better, go to the insurance commissioners in your own state. Ward's had the most experience with this, but I think it's something that we could do and advocate for this and say, look, ACC doesn't call it experimental anymore. Well, how does United get away with it? Or how does Aetna get away with it, or the Blues?
So the 2A recommendation would be for 6% and above framing of risk?
I'll have to reread, for the, it's 2A for 10 to 20. It's 2B for 6 to 10, but it's recommended. Or maybe useful or something, but it's a recommendation. It's not class 3 like it used to be.
Because that has a direct bearing on what we discussed yesterday about what we're going to do for the 6 to 10, and we said we're going to take the risk factor based approach rather than.
Right.
But we can make it equivalent. Yeah, we can write.
With that.
We can make it equivalent to that. Even in writing, we can write in such a way that fits with the ACC. That's a
right, but it's good that they have 2B for 6 to 10%.
Right. I totally agree with Michael's comments from yesterday that nobody uses Framingham, or somebody's comments from yesterday that Framingham isn't the perfect way, and we should think of other ways of utilizing the test. But I still think if we stay in that range of low intermediate, we're concordant with ACC. We don't have to be exactly word for word.
I think the other important wild card is ATP4, which is coming out next year. And I don't know if anybody here has a clue as to what their comment is going to be about incorporating imaging tests and determining the level of care.
I'm not holding my breath for ATP4, Army. I think we should just plan on ACC.
No, absolutely, but that could change the CDN, could facilitate things. If they say, if somebody has a calcium score above a certain level, then irrespective of the cholesterol, treat aggressively.
That's like dream come true. That is very, very
Right. I think the problem with NCP4, probably, and I'm not involved in it, but Scott Grundy is no longer involved, and he invented the concept of vascular aging. So with him not being on the committee, we probably lost our best advocate for that concept among NCP3. It's in NCP3, right? Calcium scoring is a useful modality in NCP3, but it may not show up in 4. So I agree with Mort. I think we should go with the ACC and not NCP.
This is a groundbreaking news to be made. Jim?
A couple things. I think ACP4 has a good chance of being mentioned in the following context. Remember, they talk about what is a CHD equivalent, and they include diabetics, and they include people with peripheral vascular disease and evident disease. I think in there, I'm not positive, but I've spoken with Bob Eckel, who's on the ATP guidelines. I think there's going to be some comment about subclinical disease being a CHD equivalent at some level. I think that's how they're going to address this on that. And as far as the insurance companies, this may be a time to be more aggressive with them. In the past, I've alerted somewhat successfully with Cigna in Colorado about the consequences of mischaracterizing a test as being experimental or investigative. They like to think that any test they don't approve by definition becomes experimental. And I alerted them formally with their attorneys what would happen, that we will support any patient who feels they've been damaged by your mischaracterization. In other words, a patient is dissuaded from having a test that would have made a difference for them, kind of thing. And then their spouse and their attorney shows up and says, we heard there was a test available. When we tried to get this test, we didn't care that you didn't pay for it, but you told us it was an investigative experimental test, and we believed you on that. So they have to think a little bit more carefully about using words like experimental investigative, because it really does not only slander the service that's being given, but it mischaracterizes this thing and dissuades people, vulnerable citizens, from having a test.
Right. No, I think that's great. I think we thought of doing something like a class action lawsuit, and the law firms don't want to take it on because they don't perceive enough dollar harm. But I think educating the insurance companies as to their thing, that's why the insurance commissioners can sometimes play leverage. I would just ask, please, we're very close with this ACC document, not to disclose anything at this point and jeopardize it. I don't want to break the embargo, but I want to share with the thought leaders that we're making great progress, and it should be a very positive statement once it does come out. It should be out soon.
Thanks, Matt, for sharing with us. I want to restate what you said. It's very essential to not leak out this message. As you know, there was an embargo a few years ago. Matt was grilled over it.
Spirit of the embargo.
So it's very important for us. So, yes.
May I ask you, what was the reason to put it at class 1? I think in Europe and Germany, judgment as class 2A will be not successful for the test to be really widely accepted. I think when you look to the evidence-based medicine, the guidelines there, it is recommended in class 1 and A judgment. If you have 2 independent studies showing the value. Many times and many years we were lacking of the argument that these studies are not available. And now 2 studies are available, observational, population-based prospective studies. Should this not be more emphasized, that this is now available? For many years we were waiting for it. The data are now present, and so the scientific value of using the test for improving risk prediction is, I think, much higher nowadays than we had it 5 years ago.
Yeah, so nothing is class 1 except for Framingham risk assessment and asking about family history. That's it. They're not going to say you must do something in everybody based on 100 studies. I mean, cholesterol testing is not class 1. Well, maybe cholesterol testing is class 1, but most things are not class 1. Almost everything is 2A, 2B, and there's a lot of 3s. You'll be surprised at a number of tests that did not score well based on the available literature that it improves risk stratification or improves outcomes. And we have people on the committee, like Mike Lauer and other people, who are going to say that until you've shown that a calcium score or carotid IMT makes you live longer, it's not going to be a class 1 indication, but nothing else is class 1 either. So in Europe, then you're going to be relegated to Framingham risk score if you're going to take this document word for word and say we're only accepting class 1 indications. So it's not, it doesn't undermine, I don't think, calcium score. It elevates calcium score and carotid IMT as strongly as anything else that they are advocating in the whole document. But I agree with you, it would have been nice to get class 1, but that was not even an option. I think we were happy to get it.
Yeah, we are very happy with the 2A. Let's move on to Canada.
Do you have it turned? I don't know what number this is.
David, do you know what number is that?
It's 15.
It's 15, the last one? Okay, if you could share your screen over there, we're on number 15.
to you, sorry.
Good morning, everyone. I'm going to talk to you about the barriers to screening, and this is coming from my own perspective from going around and doing screening programs as well as following the guidelines, etc., and looking at the literature and seeing what has been, who else has done them and what their barriers were. I first looked at the WHO principles of early detection, early disease detection, and just this is the guidelines that we need to follow. The condition should be an important health problem, which certainly peripheral arterial disease is. There should be recognizable latent or early symptomatic stage. The natural history of the condition, including development, should be declared disease, should be adequately understood. There should be a suitable test or examination, and the test should be acceptable to the population. The treatment, there should be an acceptable treatment for this disease, as there is, and when we get into the screening program, there should be an agreed policy on who to treat as patients, and this is where we use our guidelines to utilize that. There has to be the facilities, obviously, for the diagnosis and treatment, and the cost as well. And as well, we use case findings. So when you look at those and realize, yes, PAD is an important disease, it's very common, it's going to become more common, and it is a cardiovascular equivalent. The barriers to screening, these are from my own personal experience from teaching workshops at meetings as well as in family practice offices as groups of nurses, etc. Time is the #1 reason. It really is. It takes about 10 minutes to do the ankle brachial index in the office or wherever you do it, and that's a key thing. Resources, personnel, who's going to do it? From my experience, honestly, I'm training nurses to do it because of the time factor. The nurses can do it while they're taking a history. The unfortunate part is not everybody has a nurse in their office that could be able to do this for them. Lack of reimbursement. As I alluded to yesterday, there is only one province in Canada that does pay reimbursement, and it's very little, to I think $12. Disease recognition. There's a lot of people out there are not aware of PAD, and I think we show that with the public, and there is, like I said, it's just, I was recently to my own family doctor, and he talks to me every time I go, what's new in research, what are you doing with the vascular surgeons? And I said, do you do the ankle brachial index, the ABI? And he said, Marge, what is the ABI? And he's pretty up on the guidelines, and we talked about the guidelines too. So I think there is a lack of disease recognition as well as a lack of awareness and interest. But the two big ones that keep coming back, and I know from the previous presentation, is the time and the reimbursement. Those are the big issues. When I looked at the literature and reviewed the barriers from the partner study, and I'm sure you all are familiar with this, this was done back in 2000, this was done in the primary care setting. ABI included time constraints. 56% of the people said that time, lack of reimbursement, 45%, staff availability, 45%. And overall, though, people thought that it was feasible to incorporate into their daily practice. It was just a matter of, how you do it and who does it was the key things. 75 believed that the ABI was equal to or more useful than other widely available tests and reimbursed screening tests. And as I said yesterday, it does vary in the U.S. from state to state, how much you're paid, and what criteria you have to have. Most places do require the waveform to go with the actual number you get. And it is a very clinically useful diagnostic test, and if it's done correctly, it's very sensitive and specific, as I mentioned yesterday as well. It's an easy test to do. It's just a quick ankle or blood pressure, and it can be done. And this came from a paper from Dr. Moeller. The main barrier was limited reimbursement, and time, again, were key barriers to the widespread use of the ankle brachial index. So what are the solutions to this? When there's a problem, there's always a solution. So this is one of the things that we're doing at every nursing meeting we have in Canada, vascular nurses meeting. We train the nurses to do this, because I truly believe this is the group of people who are going to do it. Who are we going to screen? We use the guidelines. That's where we're going to get our best bang for our buck, is screen the people who you think are going to benefit the most and treat the patient. The patient care is of utmost priority. provide pamphlets to the patient, and the kind of pamphlets I'm talking about here are the ones that you can have in the waiting room or posters on the wall that we were talking about earlier that will alert the patient. That way you don't have to go through the whole, what you're going to do to the patient and how long it's going to take to them and the importance of the test. And I think the big thing is that clinicians have to accept their role to diagnose PAD. And we go back and forth with who's going to do it. And appreciate that this simple test, it does take a few minutes, but it's extremely important in preserving your legs and your life, because we know that if you have blocked arteries in your legs, you're most likely to have your coronaries and your carotids blocked as well. So my presentation is pretty brief. I think some of the points were captured before. It's a very important screening diagnostic test that can be performed in primary care, and it does impact patient treatment plans. There's no question about it. When you detect PAD, you want to manage these patients as aggressively as if they've had a heart attack or stroke. And it is valued despite the barriers. And how we overcome those barriers, I think we just have to educate, make it very important, that early detection and treatment is key. Without that, honestly, and I work with 4 vascular surgeons, they think they've done a great job if patients die with their limbs intact. If they keep their legs on, they've done their job. Meanwhile, these patients, as we know, like I said, do die of heart attack and stroke. That's the causes.
Thank you, Mark. Could you go back to partners, the slide that you have? I'd like to see if anybody has any comments, if this is still the case. Matt, do you still think time, the 10 minutes, is that a major issue?
It is. You know what? When you're in a busy family practice seeing 50 patients, 60 patients a day, time extra 10 minutes to do that is key. And that's where, like I said, I think it would be good to have the nurses, if you have a nurse in your office with you. That everybody doesn't have that luxury though.
It's mostly done by an MA though, right?
Yeah, it doesn't have to be a nurse. A PA and MA, anybody can do it. Any allied healthcare professional.
$12 isn't a lot, but
It
if
adds
an MA
up.
can do it in 10 minutes, then they can do 6 an hour, that's $72.
No, $12 is very low.
Oh, it's very low, but it's still,
That's in Canada.
That's in Canada, yeah.
it's still doable. I mean, if
Right.
you're not paying your MA $72 an hour, you're not losing money by offering the service.
No,
It
you're
has to
right.
be done by an RVT in this country, isn't it?
Well, in the U.S., ABI has to be done in laboratories that are certified.
Right.
And there are companies like Biomedics that they create this network that you do the test, you send the cells over the internet, and they interpret and they send it back. But the way I've seen that most of these companies promote is that practitioners do the test, not reimbursed in most cases or in half cases, but those who come with impaired ABI, they submit those results and get reimbursed.
Yeah, I was just going to make a point actually. In our vascular labs, like this is the quick screening that I'm talking about. That's $12 in the family practice office. Okay, in our vascular lab, the fee for doing an ankle brachial index, because they do waveforms, they do segmental pressures. That fee is around $200 in Canada. That's quite different than just doing the quick ABI. Yeah.
Thank you. Any comment?
In the States, probably the most common performers of ABI are companies like LifeScreen that have, they have 90 vans every day in the United States going to church parking lots, combining ABI, abdominal aortic aneurysm detection, and also carotid ultrasound, not IMT, but looking for stenosis. So they actually do a good service. The problem is that they tend to attract people who are 50, 45 years old, who are unlikely to have any of those problems. Look for late disease. But other than that, I think that's where it's going. And so a lot of physicians would do the service, but they say, hey, why don't you just go? They're going to come to the city a few times a year, just have it done there.
Those mobile service companies are actually something that we need to also talk about, because they are, in fact, the only face of the screening currently out there. We're going to move on to Raymond's experience in Germany and how Europe.
Yeah, something called from our side and from Europe. And just I want to start with this picture of two cardiologists who died, and particularly Helmut Wechsler. I think is also known in the United States and was co-editor of Circulation from Europe. And he had a sudden death on the 15th of September when he was bicycle on a Sunday morning. He died at the age of 58, huge myocardial infarction and cerebral disease, and could not be saved by surgery. And I show this image because at the moment, like in the United Kingdom, we are planning a screening program with 2,050 inhabitants of Germany, which are coming into a special screening program by the Helmholtz Institute. And I was sitting with him 6 weeks before he died in Berlin to discuss what to do and which studies we will perform. And Paul Wilson, yes, and Paul Wilson, I didn't discuss this topic with him, but of course it was also shocking that 14 days after my meeting with him in Davos, he told that, and I met him on a skiing ground, and I saw that he was not very healthy. He was exhausted and in the sports, and I think that's usually not a good sign. But these are two people, but I tell this because Wechsler was strongly against CT. Strongly fighting with me in this committee. It was an important committee meeting because it was a topic whether or not we include CT in this very important large-scale study all over Germany. You know? And he opposed it very strongly. And with wrong arguments, with the arguments of X-ray exposure, and he didn't know that the X-ray exposure already had been gone down. And I told him that screening you can do with 0.68 millisievert at the moment with the newest technology, which has of course had to be included. The study will start in 2013. So everything is there. But he was one of the, and he is a typical guy who, like others in Germany, who oppose CT from a non-rational point of view, because many years radiologists in Germany supposed CT to replace angiography. And all cardiologists are afraid, oh, they want to replace coronary angiography, despite the fact that they now know when you do it, you get more patients than before. That is one point. What is in Germany the background? I think it's quite interesting to see the development of the disease and the life expectancy in Germany and all over the world. It's very parallel. Interesting, the old East Germany and West Germany, you see that the life expectancy in East Germany for women and men was much lower than for the Western Germany. And meanwhile, over the years, you see 15 years, we have nearly the same life expectancy. And for us, the important point is to demonstrate that from the life years gained, more than 70% are related to cardiovascular improvement of therapy and prevention, which is much lower with other disease, in particular with cancer, oncology. What about the prevalence of risk factors here? The European Society demonstrates for smoking in men. We are in the middle range of 35% people smoking. And interesting, in women, Germany is very high in the upper range of the distribution in Europe. And when we look to people doing exercise, I think it's important always to look to the way of lifestyle habits. You see that Germans are quite lazy regarding those who are active in sports. And on the other side, obesity is a real problem. Here is Germany. You see the prevalence in adults. We are at the long end, and it's even more prevalence when you see it's quite small written here, but when you look to the estimate of diabetes, we are very high. We have more than 10% also in our study of diabetic patients and inhabitants. So in Germany there is a checkup program, interesting, with all those who are older than 35 years, where blood pressure, cholesterol, diabetes is done, smoking, resting ECG. I don't know how it came there, but it's resting ECG. Yeah, it came. But I'm not responsible, you know, but I'm just astonished. Yeah. And these studies are repeated every 5 years. And stress test, and that's a problem in Germany, the doctors have a budget. And in this budget is included stress ECG. And they get about 15 euro or so for the total things. Only echocardiography and CMT are reimbursed, but not CT and MRI, because when they send patients to CT or MRI, it is not it will go into their budget calculation. So they will always think about sending somebody there. And CT is the hand of the radiologist, which I think is a drawback, but it is changing. Some of the cardiologists already, like in Heidelberg, have a CT.
So CIMT is reimbursed?
Yeah, for the doctor is reimbursed. It's an additional ultrasound examination, and that is paid extra.
Paid by
the insurance.
By the insurance?
Yeah, general insurance.
Any idea how much?
I have to send it.
Would the doctor make any money?
Yeah, you get some money. Yeah, the cardiologists have, meanwhile, got to IMT, they do it regularly. So cardiologists use IMT. Yeah. The problem in medication is that we have a budget, and payment is regarded up to simvastatin. But if you want to lower the LDL more, with atorvastatin, rosuvastatin, all the patients have to pay by themselves. And they have to pay additional money, and it's a high amount, so that's a real problem for going with the guidelines. Important in Europe, there is a European charter, a prevention charter, which is accepted by more than 20 countries, but like Germany has not signed this charter, which is really a problem because we have also official prevention programs which were proposed but delayed by the politicians, and that is something which I don't see that it changes soon, because the budget of healthcare is increasing so much that they are looking for saving money, not for spending money in addition. In Germany, usually the program score is used, which is popular, but please remember, based on men and a working group of people, and quite old now, the Framingham score is not really used, and remember, it is overestimating by factor more than 2 the real risk in Germany. Viewpoint of risk groups, related strategy not known, and they are starting to do check-up clinics and risk factor analysis. Future aspects, I think prevention programs will start slowly. Some prevention centers have been created, but using only MRI without CT, also quite ridiculous. And MRI is pushed very much in Germany, even people think as a screening program for detection of heart disease. I only see one positive view in the future, that we will create a professor of preventive cardiology in Essen.
Thank you very much. This is so the IMT. This is news to me. IMT is reimbursed in Germany, and doctors are rewarded for that, reimbursed. As far as education, so you have barriers, like what to do with the result? Do they know what to do with the result?
Yeah, I think the IMT program works quite nicely. I think they still look to this by ATP programs, and so 1 millimeter cut point is in their mind, in their head, but the rethinking has already started. That is another possibility to go to the 75% percentile and percent distribution. And they are trained, they go to process and learn it, and quality controls are present. Yeah. And the second part is that ABI, due to big studies, the GET-B study, which it has been done in Germany in private practice. This GET-B program is published quite widely, and has received a lot of attention, and people look to it.
So ABI is
ABI.
also reimbursed?
I don't know if it's reimbursed, I have to check this.
Brandon, what do they use the MR for?
MRI?
Yeah, what are they testing?
Total body imaging to see if there is disease in the vessels, prostata, mammography, all organs. It's a big also discussion, but this due to the fact that there you have no X-ray, it is in their mind that's just the way to go. It's a very strong push from radiologists to go in the field, also for screening with MRI instead of CT, because they have more knowledge of MRI. That's my impression than of CT of the heart. It's a little bit more difficult to interpret.
Wow, so MRI, they detect it? MRI can detect, total body MRI can detect IMT. It can detect plaque.
Yeah, it can detect luminal so stenosis, overestimating the stenosis, but the resolution is not able to detect really definite disease of the vessel wall. They only can describe that they have irregularities or elongated vessels. As long as there's no stenosis plaque itself, it's not visualized. To visualize a plaque of the carotid artery, you need a long time of scanning.
Yeah.
The news are shortening this time, but to do it, it lasted 1 to 2 hours. So the scanning time for really imaging plaques with high resolution takes a lot of time for imaging.
Great, thank you. So, Kurt, do you want to say something about ABI, or did you put together slides together?
Yeah, I have it here.
You have it here, ready?
What I just
Sure, go ahead.
PK's involved in a study of MR in the carotids with a relatively brief protocol. It's not whole body, but for the carotids, the MR plaque characterization is excellent. I was encouraged yesterday by what we saw about ultrasound. So it may be that ultrasound will, because it's such a small machine, potentially cheaper, will give MRI a run for its money. But the MR is going to be, at least in the investigational world, a very important technique for the
Yes, I have seen a specialized carotid coil with 3 Tesla MR, good quality, but even at best, they have reached 200 to 250 micron resolution. Things that Howard showed yesterday, the kind of resolution that the IMT reaches, it's in the range of 50 to 100 micron. But you're right, that is also no radiation, but it's a lot more expensive compared to a carotid ultrasound device. Kurt, we'll look forward to your view on
Good morning. Good morning, everyone. In this presentation, I have a few things with my daughter too. She just completed world championships in ice skating, where she got 2 first places in an 11-year-old category for freestyle. So I'm gonna try that. So I have these things in here. I tried to put something together with this task that I was given that hopefully will add to some conversation of what I heard earlier and piggyback off of Marge. What she was saying, there is a collaborative care model that's out there that does for ABI, where they try to include primary care physicians, podiatric physicians, vascular specialists, the labs, the hospitals, and health systems as well. It's across the board about who should do the test, who actually should perform the test. At our university, we did ABI screenings on 160 individuals that we just picked randomly that just came in, and of those 160, 10% actually needed further testing where they had abnormal ABIs in the District of Columbia. There's several different methods that are out there. There's an ABI trainer checklist that is used, I believe, in Canada, where they actually go through a checklist of things as relates to measurements of ABI, whether it explains the purpose of the ABI to the patient, directs appropriate application of Doppler gel to the area, and etc. This is more of a checklist that the individual goes through that's going through the training process. There's another system that's out there. It's called the PadNet system. It's a little bit, it's similar in the sense to Doppler ultrasound where it uses pressure cuffs, but the PadNet looks at automated methods instead of a blood flow transducer. And this was thought to be equivalent to the blood flow transducer, according to this particular article, with an average deviation of 2 millimeters of mercury. Well, what happens with this on-site training is several things go on. It actually happens in 3 stages. There's an on-site training that clinical specialist provides training with ABIs, TBIs, and PBRs and venous refill. Then there's the content of the examination where the PadNet operating issues patient selection criteria as well as patient education. There's our skater right there. The American College of Foot and Ankle Orthopedics and Medicine actually developed the training and certification of competency for the PadNet system, and it's in 3 parts. There's the training program part, the web-based examination, and they actually have to complete 10 exams on patients that are reviewed for accuracy and quality of results. What the college does is oversees the process and competency of those performing the study to guarantee that the training curriculum for on-site trainers is of highest quality and the performance is monitored on a regular basis. And in order to ensure that the results are high diagnostic value, a formal training and certification curriculum is supplied for each individual that's going to perform the PadNet test for ABI. What this requires is formal in-service training that I mentioned, but what is included in that is basic physiology and vascular disease diagnostic methods for performing non-invasive physiological tests, and actually study performance as you see listed, which would include troubleshooting, basis of test interpretation, and understanding what the specialist needs to make the accurate diagnosis. They are given, at the end of their training, a certificate of competence to say that they're competent. The college is actually working on, right now, doing one where if an individual is considered competent in year 1, then 3 years later they would go through the process of continuous certification and competence of providing the examination. They must show the knowledge of training materials through the process that has checks and satisfactory performance at least 3 live tests. And the breakdown for the written examination would be basic cardiovascular anatomy and physiology, which would be 25%, patient selection 10%, administration techniques and operation at 30%, patient communication and education 10%, identifying and adjusting for errors 10%, troubleshooting 10%, and documentation and follow-up would be 5%. The biggest problem, I guess, with something like this is that making individuals understand the need and necessity for doing ABIs at different levels, and everyone, Marge was speaking about time as being the issue. Here you have a process where other individuals can actually do the test. The test is sent to a vascular specialist that they deem appropriate for identification, given if there's further need for testing that would go on at a higher level if there's seen to be some abnormalities. Reimbursement in the United States, as my understanding, is at different levels. There's some that allow this process to take place in some states, and there's some states that don't allow it to happen at all. That seems to be one of the barriers that is currently out there looking at ABI with individuals doing it at different test levels. But that concludes my little presentation.
Great.
Thank you.
This is actually an excellent example. I've noticed that the coalition or this academy launched a partnership with a company. That PadNet is a company. Is that right?
Yes.
How did this work? Because that's very
well, it just so happens that that college that you're speaking about, I'm the president of that college. And I actually work with a vascular surgeon. And so as we, as board members within the college, saw this and wanted to discuss with them some validity and giving their program in which they were doing some validity and actually saying that the person was going through a process that gave them some level of confidence or competence in doing the examination, and so that it would be reproducible, because some people in the community would say that, well, if you have a medical assistant or one individual doing this particular ABI testing, what level would that compare with someone in another state and how they're going through a particular process to kind of brand it so that there's some...
So it brings consistency for sure, because it's a company that has all the protocols in place, and you evaluate that company's training program, and the college basically endorses wherever the program is adopted.
The college has a board of individuals that also include a vascular surgeon on that particular committee that made up the examination and went through the process of going through the examination and continues to have a pool of questions that are rotated through on a yearly basis.
I think that's an excellent partnership, because the company has motivation and incentive to go and spread its program everywhere, and the academy college would supervise it, make sure the quality is in place, but the academy never has that kind of drive and motivation to go out and try to teach places in some doctors' offices. How is it doing now, this partnership? Is it being accepted, or is it being slowly progressing? Are doctors calling in, trying to sign up?
I think it's progressing forward. They're trying to bring on more, I heard you all talking about family practitioners. I'm actually leaving today, going to speak to a group of minority family practitioners about the importance of ABI testing and the significance of that and the relationship between what you all are talking about today. So yeah, I think it continues to move forward.
Pretty much you're in the same shoes Matt Budoff is. It's going out, creating local workshops, and trying to educate primary care physicians' office.
I just don't have as much gray hair as he does. But he's got more hair than
I. Yeah, keep going. Excellent. Bernie, we want to get the other side of the Europe's view, Scandinavian, and I know that you and Henrik Søken were front page of Danish magazines and newspapers for trying to bring cardiovascular screening to the National Healthcare Plan. Let us know what you're doing and how that will translate. I mean, I was very impressed by what Raymond showed us, that Germany has IMT, Germany has resting ECG. Those are things that are paid, and that leaves the door open for a proper program to get in.
Unfortunately, I cannot report so much, because it's correct that we have tried to introduce an updated health examination in Denmark. We have, in fact, the Danish Heart Foundation has for many years worked on have introduced a traditional health examination by measuring risk factors, and we proposed in the Danish Medical Journal and the newspaper that we should, in fact, we can do it better today than just measuring risk factor. So we presented a plan where you included measuring coronary calcification in such a health examination, and they are working on it now, and they will say after the summer they will come with a response whether we should try to do a health examination, a free health examination of all age 50 or 55, including a coronary calcification score. But we have no definite answer. So therefore I have decided to tell you a little bit about what's going on in our neighbor countries.
Your neighbor?
Yes, our neighbor countries. First, in Europe, the European Society of Cardiology's recommendation for cardiovascular disease prevention, they recommend opportunistic screening. There is no recommendation for routine or universal screening of risk factors from the European Society of Cardiology. They say you can do a global risk score based on traditional risk factors if the patient asks for it. Or if you during your consultation you see a person of middle age with different risk factors. So there is no strong recommendation from the European Society regarding screening for risk factors in Europe. Something has happened in the United Kingdom, because the National Health Service has in fact now introduced a national strategy with free screening for risk factors for all in the United Kingdom, putting prevention first, a vascular risk check. And in fact, everybody will be offered a free health examination in the United Kingdom, age 40 to 74 years old. It can be repeated every 5 years, and according to the result, they will be offered an individual tailored advice on health habits. And if the risk score calculated under Framingham or Q-risk is about 20%, they will be offered statin treatment. Here we have a diagrammatic overview of the vascular risk assessment and management program in UK that is offered for free to all. It's an organized screening program, but as you can see, it's based only on traditional risk factors. They are assessing or measuring age, gender, smoking, physical activity, family history, ethnicity, body mass index, cholesterol test, blood pressure, body mass index, and if it's high, they will examine for diabetes. But it's concentrated on risk assessment, Framingham risk or Q-risk score, traditional risk factors, and if it is high, they will be offered statin. So there, in fact, there's nothing new here other than it will be offered to all now in a formalized screening program in the United Kingdom. I think, in fact, it is a little bit depressing that they introduce today a traditional health screening program where they only measure risk factor. It is good, but we know it is not enough just to measure risk factor. Just remember what Walden Law published from UK many years ago. They say it is not advisable to screen for ischemic heart disease by measuring any combination of risk factors, and it is in fact now what they are doing in the UK in a formal way. So we know that most heart attack occur at low or average risk factor level, so I don't think there is any major progress in the recognition of how to find people with high risk and treat them appropriately. It was Great Britain. As you know, I'm coming from Denmark, and there is some way to Great Britain, but our nearest neighbor is in fact Sweden and Norway, and something has happened in Norway last year. Because last year in Norway they got a national guideline for individual primary prevention of cardiovascular disease. And this guideline was based on 3 reports from the Norwegian Knowledge Center. Very extensive report. One dealing with non-medical primary prevention, another with medical primary prevention, and a third with cost effectiveness of primary prevention. And it's the one I in fact would like to present the conclusion of this report, because they say in this report, in fact, it's the first and probably only cost effectiveness analysis using generic statin prices and generic prices for drugs lowering the blood pressure in primary prevention. And here we have the conclusion. It's highlighted in yellow, but I have translated it to English. So it's what it says here. Calcium channel blockers, thiazide, beta blockers, aspirin, or statins were all cost saving compared to no treatment for all groups of women and men aged 40 to 69. And it's new. We usually hear that these drugs to lower cholesterol and blood pressure are cost effective. It's not what it says. It is cost effective, but it's even more, it's cost saving. And it is cost saving compared to no treatment for all groups of women and men examined age 40 to 69. And I think it's something really new to know that now you can save money by treating more patients in primary prevention. It's not only cost effective. And the reason is, of course, because of this development in recent years although mortality is going down, the prevalence of the disease is increasing, and the cost is increasing because people are living longer with chronic disease, and it's a very costly disease to treat. So now the healthcare system can save money by primary prevention, by preventing people from getting sick. And I think it's something really new. You saw this picture yesterday, and you know it, and you have it here. Generic statins are very cheap, very effective and safe, and more generic statin and more powerful will soon be generic. And to lower the blood pressure, you can read it, it's in Danish, but just a few months ago, losartan is now generic in Denmark, also a very effective drug to lower the blood pressure, and it is safe and it is cheap. So now we have a very effective, cheap and safe drug with our hands so that we can prevent the first heart attack and then control the cost associated with treating this disease. So I think in fact there is a paradigm shift in the primary prevention of cardiovascular disease that is not well recognized by the community. It is that 10 years ago we could not afford to use the patent-protected drugs. But today we might not afford not to use their generic copies. And I think it's a message that we should try to get out and people to understand that we now have these very effective drugs, and in fact they are cost-saving in a huge segment of the population. The question is, are we asking the right question here also regarding prevention of cardiovascular disease? Who should we find? Those with high risk who need treatment in the traditional shape approach, or those with low risk who don't need treatment, and then treat the rest? It's two different approaches, and maybe we should use different tools depending on what patient we have or what person we have in front of us. We discussed it yesterday. Maybe in the younger age group, we should find those with high risk who need attention and need treatment. And maybe ultrasound is the right way to go here. But in the older age group, maybe the question there is,